Okay, ladies and gents, cranial nerves. So, just before we begin, let's appreciate again from our previous videos 2244, and this is your forebrain, midbrain, pons, and medulla oblongata. And what am I referring to here? Well, cranial nerve number 1 and 2 come from here, 3 and 4 come from here, 5, 6, 7 and 8 come from here, 9, 10, 11 and 12 come out from the medulla oblongata. Okay, so now that we've got that bit over, next thing in line I want to point out is these guys and then these guys, mnemonics. So remember the names of the actual nerves. Ooh, 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 to touch and feel, very good, velvet, heaven. You can change the words or have different mnemonics. It's the one that usually the first you ever remember will stick with you. And in equal fashion, there's one for the modalities, whether it is sensory, motor, or both. And the one that I've always remembered, unfortunately, is the first one. Pardon the profanity, but I'm going to go with some say marry money, but my bride says big balls matter more. Okay, now that we've got that out of the way, important things important. Naming the nerves and which numbers. And there are a couple of tricks here, and these are the tricks that kind of I picked up as I went along when I first came across them. And the two nerves I want you to really be familiar with are these two, i.e. the facial and the glossopharyngeal, followed by the trigeminal. And so facial nerve, F looks like a number 7 when you look at it in a mirror reflection, and so therefore 7 is facial. And G can be written like this and like so, and that looks like a 9, and therefore glossopharyngeal. Okay, trigeminal, we know tri means 3, except that's the anomaly, and it's cranial nerve number 5. Vagus, I think the vast majority of people know it's cranial nerve number 10 anyway. So you've got the head start there with 3, possibly 4 cranial nerves, appreciating there are 12 pairs of cranial nerves, 12 on the right hand side, 12 on the left, equaling 24 in total. Appreciate they originate in the central nervous system, as we pointed out here, in the forebrain, midbrain, pons and medulla, but of course they come out into the peripheral regions and therefore can be classified from that part on as peripheral nerves, i.e. the lower motor neuron. So remember, they are upper motor neurons whilst they're in there, and anything that's upper motor neuron based is in the central nervous system, i.e. the brain and the spinal cord. Hence, when we say upper motor neuron lesion, this is a lesion, a disorder in either the brain or the spinal cord. Anything that is lower motor neural lesion is anything in the peripheral nervous system. So these two kind of abbreviations, UMNL and LMNL, are things that you must become familiar with. Okay, now the actual cranial nerves themselves. So I'm going to start us off with cranial nerve number 1, olfactory. Now olfactory is to do with the smell, and you may well be familiar with this little diagram here. And what we've got is we've got the olfactory nerve with the bulbs descending here inferiorly, and these actually pass through the cribriform plate. Now cribriform, if I remember correctly, means sieve-like, so there are lots of holes in the cribriform plate through which these olfactory bulbs descend. And if you look at the rest of this, essentially is your nose, and essentially the smell goes in there, and that's how we use our smell. Now, important things to consider here are the concepts of smell and anosmia. Okay, this is anosmia, not insomnia. And then we have the term hyperosmia. Okay, and we also have, of course, hypoosmia, if you wanted to refer to it. Now, anosmia, again, an as in absence, hyper increased, hypo reduced, so hyponosmia, common cold, common flu, any obvious things like that. Could be a little foreign body there, of course. Anosmia, again, This is more definitively kind of nasal polyps as a kind of actual pathological reason. And then we have hyperosmia, and the important things to remember with hyperosmia are epilepsy and pregnancy in a female of childbearing age. Okay, so these the more important things here to remember are these, but never forget to say the more basic ones: cold, flu, foreign body, these kind of things. Of course, don't forget, also appreciate with age, kind of after 60 years of age, we start to reduce our level of sensation anyway, and women usually lose theirs before men do. Okay, next in line we have the optic nerve. So I'm just going to change my pen here so as to ensure we've got plenty of colour. Optic nerve, cranial nerve number 2. I'm not going to say too much about this one. I'll go this way for this. Cranial nerve number 2 passes via the optic canal, and the key thing here we want to remember is the concept of optic neuritis. Okay, itis means inflammation, and neuro as in nerve, inflammation of the nerve. Which nerve? The optic nerve. And this is actually one of the first signs of multiple sclerosis. So therefore, if you have a female in her 30s originating from the equatorial regions with optic neuritis or blurring of the vision, be it unilateral or otherwise, pain in the eye sometimes, again, consider multiple sclerosis. Moving on from that, we then have in line, so let's change pen again, let's go purple here. Number 3, number 4, and number 6. Okay, these three come together. And why? Because they are all motor, as you can see over here, and these guys innervate the extraocular muscles of the eye. So extraocular referring to the eye, extra outside, of course, the muscles that control the eyeball. So this is movement of the eyeball itself. Okay, and in order to test this, we perform what we call the H test. And what we do is we ask the patient to keep the head still and follow your finger as you draw out a H in midair. And you're looking at the eyeballs and ensuring that they move all around. Now, important thing here, take home, is SO4, LR6. And what I'm going on about here is all the extraocular muscles are innervated by the oculomotor nerve, except the superior oblique is innervated by the trochlear nerve, and the lateral rectus is innervated by the abducens nerve. So SO4 LR6, it's very, very, very important that you remember that, and that's this bit over here. Okay, next in line we have trigeminal. Where shall we try trigeminal? Let's change. Let's go blue here. Okay, so let's go trigeminal down here. Now, trigeminal has got 3 branches: V1, V2, and V3. V1 is your ophthalmic division, and V2 is your maxillary division, and V3 is your mandibular division. Okay, so you have sensory aspect. So these 3 regions, again, sensory features, but notice it is both sensory and motor, and the motor aspect is the muscles of mastication. Notice it, mastication there, and that is chewing. Okay, mastication is chewing. So what we do is we do the sensory testing for these guys over here, sharp and dull, in the 3 different regions, and then we do the muscles of mastication, as well as the corneal reflex if it's warranted. Important thing here to remember is a condition called TGN, and that stands for trigeminal neuralgia. Now, neuralgia means algia means pain with the nerve. So which nerve? Again, the trigeminal nerve. And this is horrible pain. Usually affects the V2, V3 and then V2. Rarely affects V1. And what it gives you is lancinating pain. It is in fact the most common cause of suicide out in the US. And in older patients, the same thing we call tic douloureux. Okay, that's what it's called in the older patient. That should be DOU. Okay, next in line we have facial nerve. And so let's go with facial. Again, appreciate how we remember facial nerve. Yet again, a very important nerve. Exits the cranium via the stylomastoid foramen. And where is the stylomastoid foramen? Well, it's between the styloid process of the temporal bone and the mastoid process. Why is this important? Well, because mastoid, if again, when we're assessing the facial nerve, we will look in and around the ear. We'll look for the mastoid. If there's any redness, pain, swelling, tenderness, bogginess, that will indicate mastoiditis, inflammation of the mastoid process. Now, if you get this, if you see this in clinic when you're examining a patient, big warning signs ring and you send the patient to A&E as a matter of urgency, and the reason being complication of mastoiditis is meningitis, so do not take any risks with that. Now, while we're on this bit, what we have is this cranial nerve number 7 has 5 branches, and the way I remember the 5 branches is 2 zombies broke my car, and what we've got is a temporal, we've got the zygomatic, we have the buccal, we have the mandibular, and we have the cervical. Now the cervical innervates your platysmus muscle, the mandibular innervates part of your parotid gland and salivaries and bits and bobs. The temporal branch innervates your temporalis muscle, so clenching of the jaw. When you place your hands on your temples, you can feel it, and it's one of the assessments we do in trigeminal nerve. Now the other important bit, and that's part of the motor and sensory, the other bit is the anterior 2/3 of the tongue. Okay, that's the sensory, and then there's one other important bit, and the stapes muscle. Okay, or the stapedius muscle rather, which is attached to the stapes bone. Remember, in the inner ear, we've got the smallest bones in the body: the malleus, the incus, and the stapes. And what it does is the stapedius muscle actually is attached to the stapes, and it kind of dampens the sound that we hear. Now, if there is damage to cranial nerve number 7, that is not happening, and therefore we get what we refer to as hyperacusis. So you get super hearing, like Superman, for a little short while in that situation. So that's your cranial nerve number 7. Any of the important bits there? Oh, Bell's palsy. So the other really important thing is Bell's palsy here. Okay, so Bell's palsy essentially is an infection to cranial nerve number 7, and it will give unilateral facial paralysis. Okay, unilateral facial paralysis. Now we have to be able to delineate this from a CVA, i.e. a stroke or a TIA, and there is a clinical way to do that. I've done a separate video on that explaining how we delineate in the clinical setting. Okay, moving on from here, then let's go to the vestibulocochlear. Now this one's a fairly straightforward one. There's not much to be said here. And what we're going to say essentially is the cochlea is in the inner ear. The vestibular apparatus is to do with balance, and so this is basically all to do with hearing. Bit boring, really, I'm afraid. More exciting is glossopharyngeal. So let's move on to glossopharyngeal and come down this way for this one. Okay, so glossopharyngeal, really important and interesting. So there are, again, both sensory and motor aspects to this. The sensory aspect is the posterior 1/3 of the tongue, as well as the oropharynx. And this is really important. Why? Because if you appreciate, when you touch the back of your mouth in this soft palate, okay, and that's where the oropharynx is, or if you hit the back of your tongue, if you touch the back of your tongue with a toothbrush or something, it initiates your gag reflex agreeably, okay, you feel like you want to retch. And so if you have damage to this, the gag reflex is lost. Okay, that's the initiation. The actual reflex itself is actually triggered by the vagus nerve. But if your sensation isn't there in the first place, then you can't actually initiate. So the efferent fibers are no longer working, so you can't actually initiate that reflex arc concept. And that's super duper important over here. The other thing we need to appreciate here is the vagus nerve then. And And let's go back to vagus. Let's go with this one for vagus. Now, vagus comes from the term vagrant. That's where it originates. Vagrant means wanderer, because of course, as we know, it goes all the way down to the GI tract. Appreciate, again, remember this guy has a parasympathetic influence on the on your SEN, your sinoatrial node, and that parasympathetic influence on the sinoatrial node causes the heartbeat to actually reduce down to around 72 beats per minute. If it wasn't for that, then you'd be sitting more around the 100 beats per minute. Okay. Now, the important thing with vagus is that it actually innervates the muscular component of the soft palate, so muscles of soft palate. Okay, now if you look at inside the oral cavity, let's say that's the oral cavity, and when we look inside, you have the uvula here. Okay, that's the dangly bit, and there's your teeth, and there's your little lips, and there's another set of lips, and there's some more teeth if you want. Okay, so here is our uvula. Okay, hanging. Now, when we actually say test for this, what we do is we say to the patient, say "ah." When they say "ah," which is again initiated by your vagus nerve, the phonation side, the soft palate rises because of these muscles being innervated. Okay, now if there is a lesion, if there is damage to this nerve over here, let's say for example, this muscle won't work, so this one will rise. Now, if that one rises, you'll appreciate the uvula will then do this, so it will deviate that way because that's risen. Let's delete that a little bit. Oh, it's all gone. Okay, fine. So deviation because that stayed down here, whereas that rose in that oral cavity. Yes, and so you get uvular deviation as a result of that. The other thing to appreciate vagus is also the swallowing. Okay, so it also controls muscles of swallowing, i.e. your pharyngeus muscle, and that again in the context of stroke, we do what we call SALT assessments, and if you have anything there, then we again need to appreciate the integrity of vagus nerve. Okay, nearly finished, I promise. Moving on from here to the, let's go with orange, accessory nerve. Where can I go? Yeah, oh, plenty of space. So accessory nerve. Let's go with that. Accessory simple. You're going to innervate the upper traps, so you're going to get the patient to shrug. Very boring, really. And you're going to assess the accessory nerve with that. And finally, we've got the hypoglossal. And the hypoglossal, remember, hypo meaning underneath, glossal referring to tongue, because you had glossitis in the abdo examination. Remember, when we get itis, inflammation of the gloss, i.e. the tongue. So hypoglossal nerve, again, really important because it innervates the muscles of the tongue. And again, really important concept I'm going to just very quickly share here is that you have, here's our tongue, and you have kind of the fissure down the middle. You have one hypoglossal nerve on this side, and you have one hypoglossal nerve on this side. I'll undo them because it, yeah, okay, one on this side and one on this side. Now here, if I cause a lesion on this side, what's going to happen is the muscles on this side are not working, whereas these are. So then when I push out, what's going to happen is these muscles are going to be more powerful than these guys, so you're going to get deviation of the tongue doing that, so it's going to deviate. Now if you appreciated earlier, my uvular deviation here was away from the side of lesion, because the lesion is here and it's deviating away from the side of lesion, whereas here it's deviating towards, appreciating the lesion is on the same side. This is towards the side of lesion, and T for towards and T for tongue. And there you have it, my good friends. That's your cranial nerves. A good overview, partly also to do with the examinations. Again, I've not actually given you how to examine, rather just some really good clinical information and how to perhaps try and remember some of the bits and bobs associated with cranial nerves, and generally very high yield in a clinical setting, both for OSCEs and MCQs. Thank you for watching.